Dr. Lukoff, would you state your credentials for the court, please, and what your line of work is currently?
Well, I'm a licensed clinical psychologist and have been for 40 years. My area of expertise has been the intersection of spirituality and mental illness. I've been involved in a number of research projects teasing out that interface and have had some role in the field as a whole in bringing spirituality and mental health closer together.
Thank you. Now, I'm holding in my hand the DSM-4, Diagnostic and Statistical Manual of Mental Disorders. Dr. Lukoff, would you tell the court what this is and how is it used?
Well, the DSM-4 you're holding is out of date because they're now already on the DSM-5. It's that DSM stands for Diagnostic and Statistical Manual. People kind of jokingly say it's the Bible of mental health because every mental health professional, from nurses, psychologists, social workers, and psychiatrists, have to make use of this system to render a diagnosis. And that's certainly part of the standard of practice for working with any kind of mental problems is to make a diagnosis that has its basis in the Diagnostic and Statistical Manual.
Thank you. So would you please turn to the diagnosis of spiritual disorder in the DSM? Or the diagnosis of spiritual transformative experience, either one?
Well, neither of those are the terms that are used in the DSM. The category that is actually in the DSM is called religious or spiritual problem. Now, if you go into the history of that category, because it was new for the DSM-4, you will find other terms being used by people in the field, including me and many others, terms like spiritual emergency, spiritual crisis, spiritually transformative experience, extraordinary experiences, exceptional experiences, and so on. So there's a variety of terms that have been used in kind of recognition of this overlap between spirituality and mental illness, particularly psychosis. But the term that's actually used in the DSM that would be closest to those is religious or spiritual problem.
So is that to say that spiritual experiences are not mental illness?
Correct. First of all, generically, I can say that's correct. And even within the DSM, the term spiritual problem is not a mental disorder. There's a section of the DSM that is called other conditions which may be the focus of clinical attention. Bipolar is considered a mental disorder. Schizophrenia is a mental disorder. Obsessive compulsive disorder, those are all considered to be biologically based mental disorders. Then there's a section of the Diagnostic and Statistical Manual for other problems that mental health professionals routinely deal with, like marital problems, occupational problems, and religious and spiritual problems, which mental health professionals are often dealing with, and there's many surveys demonstrating that, but which are not considered to be biologically based mental disorders or mental illnesses. The DSM does not use the term illness. It actually does use the term disorder.
And from what you're saying, the spiritual experiences that are addressed in the manual, it sounds like, are not considered disorders, but problems. They're framed that way. Is that accurate?
Yeah, I mean, not all spiritual experiences, of course, are problems. It's only a problem if somebody seeks out a mental health professional to go into some depth about it, likely because it is causing them some distress. But the category religious or spiritual problem is used in the field to show that we're dealing with an issue that is not a mental disorder. It is causing the client some stress and is an area of concern of theirs, and it's any competent mental health professional would may be empowered by having that diagnosis to delve into that. Now, I want to point out that was 1994. When I was in my training program back in the 1970s, we were literally told if a client wants to talk about anything pertaining to religion, we were not competent to address it, and we should refer that client to a religious professional, a priest, a rabbi, an imam, or somebody like that, but that we as a psychologist should not address it. So the DSM was really a breakthrough in that it opened the door. It basically said, of course, mental health professionals need to and have the, now in the DSM, the right to delve into religious and spiritual issues that a client wants to discuss.
Thank you. I've turned to the page where spiritual and religious problems, V Code 6289, is in the DSM-4, the 1994 that you mentioned earlier, and which you were instrumental in establishing. Can you please tell the court what motivated you to lead the way in establishing this V Code?
Really, that has been a focus of much of my work, trying to identify spiritual experiences that may be problematic for a client, but are not mental disorders. And there was really a movement, it really started with Stan Groff, who is a psychiatrist, and his wife, and I'm not aware of what her background is professionally, but they started something called a spiritual emergency network. Both of them were very active workshop leaders. And what they found is that many people who would go through these intensive workshops that they offered sometimes had lingering issues after the workshop because they felt like their life had so radically changed. They were a new person from being exposed to a lot of the spiritual practices that Stan and Christina Groff really were pioneers in bringing into the mental health field. But what I don't know if I should say they felt guilty about, but they were concerned that some of these people were ending up hospitalized when there was really, if somebody like Stan or Christina Groff could just sit down with them, they could basically talk them through it. Sort of the way at places like Burning Man, they have a location where people who are having bad drug experiences can go, and somebody talks them down. Somebody helps them to get a perspective, maybe teaches them some breathing techniques if they're getting anxious, gives them feedback that they're not having, that they're not crazy, and so on. So we already knew from some of their work, because they actually did at times do that. And then they wrote a book on that called Spiritual Emergency. So we already knew that people could really benefit from having an experience, even if it's distressing. But if it deals with spirituality, not be labeled as psychotic or crazy, but give them the opportunity to go into some depth and explore it in an environment that acknowledged them and didn't pathologize their experience.
Mm. Was there any particular seminal event that moved you to be so interested in this field that you would say the Groffs in some way seemed to pioneer?
Well, yeah, I did have a personal experience along these lines. I don't know if that's what we want to go into some depth about. I have written about it. It was triggered, in my case, by a psychedelic drug. The first time I took it, and unfortunately, we know much better now that guided experiences really are the way to go to render psychedelics safe and even therapeutic. But like many people in the 60s, actually, my experience was in 1971, but culture, when we talk about the 60s, we're really talking about like 1965 to like 1973. So I'll call it the 60s. Like most people in the 60s, I just ingested it and ended up going through a 2-month period of believing that I was a reincarnation of Buddha and a reincarnation of Christ, and that I was founding a new world religion. And I have actually encountered other people who have had almost an identical experience to mine, some not at all triggered by psychedelics. So I did write several articles on this phenomenon. I wrote one called Diagnosis of Mystical Experiences with Psychotic Features. And that was the first time that I broached the issue of a DSM category for these things.
Mm.
And then I was very active in the Spiritual Emergency Network. I was there when Stan and Christina Groff founded it in 1980. And then we wrote a number of articles on this. We organized a number of conferences. And the conference that was the most pivotal in this area was in 1989 in Monterey, California. And I was one of the organizers of it. And we had 500 people who were really interested in this intersection of spirituality and psychosis, because most of them were mental health professionals, and they were seeing it in their clients. And my guess is that now that psychedelic use is on the increase, therapists will see more and more of these kinds of situations. But after that conference, those of us who had organized it held a kind of Monday morning, quarterback assessment, like, how did the conference go? What was, successful? What wasn't successful? But then one of the points that we started discussing was, are we just preaching to the choir? This limited group of people who have some familiarity with this niche called transpersonal psychology, and that we really were not impacting mainstream mental health. So at that meeting, there was a psychiatrist, Dr. Francis Liu, and he and I, and neither of us remember who actually proposed it first, but he and I both argued that, well, the way to really get recognition for spiritual emergencies would be to get a category into the DSM. Mm. And of course, then everyone looked at us, because I'm a licensed psychologist. He's a licensed psychiatrist. He's on the faculty at, in those days, it was UC San Francisco. I was on the faculty of a graduate psychology program. And so people kind of turned to us and said, well, why don't you do it?
Get after it.
Great idea. Why don't you do it? And we kind of gulped, but we decided to explore that idea. And we knew that the DSM-4 was already, the task force was already meeting and considering new diagnostic categories and refinements of other categories from the DSM-3 and so on. And so we started the process of collecting the evidence, surveys showing that therapists, psychiatrists, psychologists, social workers all say when they're asked in surveys that they have a high percentage of clients, a majority of clients, 72% one survey, that bring up religious and spiritual issues in therapy. And we also, I was able to track down a number of case studies that were published in journals of psychiatry and psychology. And we were also able to collect evidence that underserved populations, minority populations, one of the factors that actually the Surgeon General report in 1999 nailed this point, but we made the point in some of our earlier articles in the early 90s, that one of the reasons that some of these populations are underserved is because their religious and spiritual beliefs are so important to them that if they are not acknowledged in their treatment, that they drop out. There's a high dropout rate amongst minorities, African Americans, Asian Americans, Pacific Island Americans, Native Americans, and so on. So, and as I say, the Surgeon General report in 1999 that came out really demonstrated this with some even more powerful research, but we were arguing that already as part of our rationale for this DSM category. So we collected the research on this. We published a few articles, and one of the articles we published was in one of the leading journals of psychiatry. It's called the Journal of Nervous and Mental Disease. Even that title shows you how old it was. I think it started publishing in like the 1870s. It was one of the first journals in psychiatry, and it is still one of the journals that has the highest impact rating in the field. And we were able to get an article into that journal right before the task force on the DSM-4 was holding their final meetings. We had already presented this as a proposal to the task force, but the task force, they get a lot of proposals for new diagnostic categories and for modifications and so on. So, it was really hard to get their attention about this need for a new category on spirituality. Most of them rolled their eyes when it was even discussed. But I want to give Francis Liu a lot of credit here. He was very active within the American Psychiatric Association. He's a Chinese American, and he was already very active in a cultural sensitivity group that was part of the American Psychiatric Association, and they specifically had a contact with the task force on the DSM-4, because one of the goals of the DSM-4 was to make it more culturally sensitive. So by getting them involved in supporting our proposal, which Francis Liu was able to do, he actually got a letter of support from this I think it was called like the Group on Cultural Sensitivity or something like that. He actually got a letter of support from them for our proposed new diagnostic category. And then there was also a group in the American Psychiatric Association, and I'm pretty sure it was just called a Group on Religion and Psychiatry. We should find out the exact terms, but he also got them to support our category with an actual letter to the task force. And then this is an interesting political point here. The editor of the Journal of Nervous and Mental Disease, once our article was accepted, it was put in the queue for publication. But the queue for publication was over a year. And he knew that the task force was having their final meetings well before that. So he actually moved it to the front of the queue.
Mm.
And it was actually published a month before this final series of meetings. And it was actually the lead article, if I remember, we should check that, in that journal for that issue. And Francis Liu made photocopies of this article and made sure that everybody on the task force had that as part of their packet for these final deliberations. So that's kind of a little of the politics of what went into this. It isn't just like you send in a proposal and expect they're going to take it seriously. Mm-hmm. We had to do all this politicking, and Francis Liu is certainly the person who deserves the credit for astutely moving this forward so that it was credible. I don't know if this is a point to make at this time, but it was we went back and forth with them, because one of the first things they said was, well, all right, if we need to do this, let's just call it a religious problem. Why have spirituality in there? So again, that kind of fell into my lap, but I had to look through the research to show that the percentage of people in the United States who consider themselves spiritual but not religious was already pretty substantial back then. It has exploded since then. It's actually now a majority of people who are millennials and Gen X's and so on consider themselves to be spiritual but not religious. But there were already surveys showing that like 20% of the population held that belief back in the early 90s. So we went back and forth with them about that and so on. And then finally, yeah, it was
accepted.
It was accepted, yeah.
So with that background, very helpful background, Dr. Lukoff, and we have just a few minutes remaining at the moment. How do professionals differentiate now between spiritual experience and psychosis?
Well, first of all, I want to make that point again that they overlap. So there are times one can be pretty confident about this, but there's a lot of times where there's enough overlap that we can't be sure. I have discussed in some articles some of the criteria that can be used to make this distinction, and I'll mention one that I think is a good starting point, which is to look at what are called good prognostic signs. These are signs, and that term is used in the medical field, not just in psychiatry, but it applies to psychiatry, and there's research on this too. What is a good sign if somebody's having an episode of psychosis? What is a good sign that they're going to bounce back?
Hmm.
So things like what was their level of functioning before the episode? Were they already isolating? Did they drop out of school? Did they lack intimate connections with family? Did they have a boyfriend or girlfriend? Did they have a job, et cetera, et cetera? If those are present, that's a good indicator that that person is likely to bounce back. Was the onset prolonged, or was it acute? An acute onset has a much better prognosis. And there are a couple of other of these kinds of criteria that one can use to make a guess about what's more than a guess. It's a very informed guess. But I want to point out not only that area of overlap, but there have been a couple of studies. A famous one that I think will bear talking about in this context. It was at Soteria House, and what they did is admit everybody who was having a first psychotic episode into a program where they were not given medication, they were not assumed to be psychotic, even if they were having hallucinations or delusions. They were allowed to go through the entire experience with just in a safe environment, so they couldn't run out into the street. Somebody was always kind of monitoring them. They were allowed to not only talk about their experience, but write about it. There were art materials so they could express what was going on with them. If they wanted to pound, they had mattresses so they could let out some of that energy. If they were having trouble sleeping, they helped with that, because that can really be a driver for a psychotic episode. If a person doesn't get any sleep, that'll just continue, and so on. And what Soteria found was that if you took that approach, about half of the people in their first psychotic episode will remit without any need for medication, and will not get rehospitalized. So there are some programs now in the United States and in Europe that take that stance. And really, that's the stance that I would argue is the most relevant for somebody in a spiritual emergency. Let's see how it goes. Let's give them a safe environment to express what's going on, to start eating regular meals, getting sleep, have contact with people so they're not just going further and further and further into their ruminations and so on. And a high percentage of them will remit. And there have been some other studies. There was one at Agnews Hospital where they did the same thing and also found that about 50% of people, if they're treated without medication, but just a safe environment, will also remit. So, even though it's very difficult to make this distinction in many cases, I think the outcome studies that I've cited really would argue for allowing somebody who's in that psychological space of a spiritual crisis go through it so that they have the opportunity to integrate it on their own without medication. And what happens with medication is it often terminates these symptoms very quickly, within a few days, but the person is often pretty, hobbled by the experience. They've now been told that they have a mental disorder. They may not have hallucinations and delusions, but they're they haven't had a chance to really integrate the experience, so they're probably still thinking about it a lot. They haven't had the chance to do the kind of therapy that would go into the experience and help them separate the wheat from the chaff of the experience, which parts of it are universal spiritual experiences, and which parts of that experiences of their experience are more personal, unconscious experiences from that childhood traumas and so on. Because in psychosis, they all get mixed together. And that's where psychotherapy can be very useful. Medication does not allow a person to parse those experiences, see what was useful, what they could learn from it, and so on.
Thank you very much, Dr. Lukoff. Given the court's timing, we're going to need to have you back on the stand because you've given us a lot of rich information about the difference between what is deemed an illness in professional terms and what is deemed a problem to address. So thank you so much for that, and we will have you back when it is feasible for you and the court.
Okay.